Good afternoon, students. I am Dr. Lisa Kalimag, and today I will be tackling Introduction to Epidemiology. These are the objectives of the session. At the end of the session, the participants shall be able to define epidemiology, identify selected activities performed in epidemiology, explain the importance and application of epidemiology in the practice of medicine, and understand the basic vocabulary used in epidemiology. So epidemiology is the basic science or foundation of public health. Defined, it's the study of the distribution and determinants of health-related states or events in human populations and the application of the study to the prevention and control of health problems. The root word for epidemiology comes from the Greek epi, meaning on, upon, or befall, and demos, meaning the people, and logos, meaning the study of. Epidemiologic investigations involve descriptive and analytic methods that draw on statistical techniques for describing data and evaluating hypotheses, biological principles, and causal theory. Disease is not randomly distributed throughout the population, but rather groups differ in the frequency of various diseases, and knowledge of this uneven distribution can be used to investigate etiologic factors and to lay the groundwork for programs of prevention and control. We now go to the historic developments of epidemiology. These are people who advance the study of disease from a supernatural viewpoint to a viewpoint based on a scientific foundation, from no approach for assessment to systematic methods for summarizing and describing public health problems. First off is Hippocrates, born in 460, lived until 377 BC, so no need to memorize the dates, okay? Hippocrates is the father of medicine, and he is also considered as the first epidemiologist. He observed on how diseases affected populations and how disease spread. He also introduced terms like epidemic and endemic. For example, he noted that malaria and yellow fever most commonly occurred in swampy areas. It was not known that time that the mosquito was responsible for such diseases, but at least he was able to identify the localities where malaria and yellow fever most commonly occurred. Next is James Lind. In the year 1754, he wrote the book, A Treatise on Scurvy. He was able to identify the symptoms of scurvy and the fact that the disease became common in sailors after as little as a month at sea. Lind pointed out that the months most common to scurvy were April, May, and June. He also observed that cold, rainy, foggy, and thick weather were often present. Being influenced by the Hippocratic theory of medicine, Lind kept looking to the air as the source of disease. But later he discovered in his clinical trial in scurvy the real cause of the disease. So 12 ill patients who had all of the classic symptoms of scurvy were assigned different supplemental dietary interventions. So there are 6 interventions with 2 patients per intervention. So one intervention was a quart of cider a day on an empty stomach. Next was 2 spoonfuls of vinegar 3 times a day on an empty stomach. The other group was given half pint of seawater every day. Another group was given lemons and oranges to eat on an empty stomach. Another group was given elixir recommended by a hospital surgeon, and another group was given a combination of garlic, mustard seed, and horseradish. So just like trial and error. And Lind says that the men given the lemons and oranges ate them with greediness, and the most sudden and visible good effects were seen in those who ate lemons and oranges. And in 6 days, the 2 men eating citrus fruits were fit for duty. So now we know that we later found out that vitamin C is the lack of vitamin C is the cause of scurvy, which is present in the citrus fruits. Next is John Snow. He was the anesthesiologist for Queen Victoria of England and is considered the father of modern epidemiology. He observed and recorded important factors related to the course of disease in cholera in the 1850s. We still use the methods that he pioneered, especially in how to investigate an outbreak or epidemic. Snow conducted two major investigative studies of cholera. The first involved a descriptive epidemiologic investigation of a cholera outbreak in London in the Broad Street area. So, Broad Street. By using a spot map, he found that nearly all deaths had taken place within a short distance of the Broad Street pump. He later prohibited the use of that pump. The second involved an analytic epidemiologic investigation of a cholera epidemic in which he compared death rates from the disease to where the sufferers got their water. So the death rate was 71 per 10,000 in Southwark and Vauxhall households. This is the water company, Southwark and Vauxhall. And the death rate was 5 per 10,000 in households supplied by the Lambeth Water Company. And the difference between the two companies was that Lambeth was able to draw water free from London sewage. This proved Snow's hypothesis that contaminated water passing down the sewers into the river, then being drawn from the river and distributed through pipes into people's homes, produced cholera throughout the community. Going back in time to 1620 to 1674 was John Grant, who made a systematic recording of deaths, which was called the Bills of Mortality. He systematically recorded ages, gender, who died, what killed them, and where and when the deaths occurred. He also recorded how many persons died each year and the cause of death. This was the first major contribution to record keeping on a population and was the beginning of the vital statistics aspect of epidemiology. 200 years after John Grant, it was William Farr who built on John Grant's ideas. Farr extended the use of vital statistics and organized and developed a modern vital statistics system, much of which is still in use today. He also aimed for better disease classifications and international uniformity in their use. His classification of diseases later became the basis of the ICD, or the International Classification of Disease. Next, we go to concepts and terms in epidemiology. These are the broad categories in epidemiology. We have descriptive and analytic epidemiology. Descriptive epidemiology deals with is the study of the amount, frequency, and distribution of disease, etc., in populations. While analytic epidemiology is the study of the determinants or etiology of disease and related conditions. So remember, analytic, you are studying the cause and effect, while in descriptive epidemiology, you are just describing where, when, and how the diseases occur. The aim of descriptive epidemiology is to permit evaluation of trends in health and disease, provide a basis for planning, provision, and evaluation of health services, identify problems to be studied by analytic methods, and suggest areas that may be fruitful for investigation. So you start first with describing the patterns of disease, then later you move to analytic methods for analytic epidemiology to determine the causes of disease. For descriptive epidemiology, for almost all diseases and illnesses, there are three basic epidemiologic questions which may be asked. First, who develops the disease? These are the person variables. When does the disease occur? These are the time variables. And where does the disease occur? These are the place variables. So for person, you can describe the persons who get the disease in terms of age, sex, race and ethnicity, civil status, among so many other person factors. Then for place, you have global, national, and local. You can describe it at the province level, city, municipality level, barangay level, or even in smaller localities such as a specific water source in a barangay. For time, you can describe it as seasonal or cyclic, secular trends, or epidemics. So to clarify secular, the secular trend represents the long-term changes in health-related states or events. Secular trends are usually considered to last longer than 1 year. Example is the increase in non-communicable diseases such as hypertension and diabetes over the course of many years until now. This can be considered a secular trend. Epidemiologists may be involved in a range of activities such as identifying risk factors for disease, injury, and death, describing the natural history of disease, monitoring diseases and other health-related events over time, evaluating the efficacy and effectiveness of prevention and treatment programs, providing information that is useful in health planning and decision-making for establishing health programs with appropriate priorities, assisting in carrying out public health programs, being a resource person, and communicating public health information. Uses of epidemiology in public health policy and individual decision-making. For assessment, epidemiology can identify who is at greatest risk for experiencing the public health problems, identify where the public health problem is greatest, identify when the public health problem is greatest, so where and when, monitor potential exposures over time, and monitor intervention-related health outcomes over time. So we have, for example, surveillance systems that monitor the morbidity and mortality of the community by person, place, and time. Public health departments usually have surveillance mechanisms to have information about disease epidemics, statuses of vaccination and prevention programs, and health disparities among special populations, which is important for initiating and guiding action. Under cause, epidemiology can identify the primary agents associated with disease, disorders, or conditions. It can identify the mode of transmission, and it can combine laboratory evidence with epidemiologic findings. Under clinical picture, we can identify who is susceptible to the disease, identify the types of exposure capable of causing the disease, describe the pathologic changes that occur, the stage of subclinical disease, and the expected length of this subclinical phase of the disease. You can also identify the types of symptoms that characterize the disease and identify probable outcomes such as recovery, disability, or death associated with different levels of the disease. We can also identify the efficacy of the public health program and measure the effectiveness of the public health programs. So to differentiate efficacy and effectiveness, efficacy is when you have complete resources for your public health program. So what will be the effect of the public health program on the health outcomes? The difference with effectiveness is effectiveness considers the real life variables such as considering cost, availability of resources, and feasibility of the public health program. So it's kind of like cost effectiveness and those other measures. Historically, epidemiology was developed to investigate epidemics of infectious disease. So let's define an epidemic. An epidemic is an occurrence of cases of an illness, specific health-related behavior, or other health-related events clearly in excess of normal expectancy in a community or region. An outbreak is an epidemic that is confined to an even more localized area. And an endemic is an ongoing, usual, or constant presence of a disease in a community or among a group of people. For example, we always have dengue cases in our country. But there can be, so that would be the endemic level of dengue. But there could be higher cases than the usual, so that would be an outbreak or an epidemic. A pandemic is an epidemic affecting or attacking the population of an extensive region, country, or continent. So in the endemic, you have the diseases in low frequencies in their respective localized areas. And then for epidemic, you have an increase in the number of cases. And for pandemic, you have spread to different countries and continents. So this is when you have an epidemic or outbreak, it exceeds the outbreak detection level, parang may cutoff for when to call it an epidemic or outbreak. So this one is an undetected outbreak since it did not reach the outbreak detection level. And then here we have the endemic, so it has a low level of frequency. Then we have sporadic, which is an infrequent or haphazard or irregular occurrence of those cases with no discernible temporal or spatial pattern. Let's move to case concepts in epidemiology. So a case of a person is a person in a population who has been identified as having a particular disease, disorder, injury, or condition. When we begin studying outbreaks or epidemics, we need to set a case definition, which is a standard set of criteria which ensures that cases are consistently diagnosed, regardless of where or when they were identified and who diagnosed the case. So we need to have consistency. That's why, for example, during the COVID pandemic, there were always definitions of COVID, which could be defined as a probable case, which would be a suspected case, which would be a confirmed case. So all of those would have their own definitions. The primary case is the first disease case in the population, the first occurrence of that disease in that population. The index case is the first disease case brought to the attention of the epidemiologist or the first that the epidemiologist investigated. So the primary case is not necessarily the index case. It could be that the primary case is undiscovered, while the index case is just the first one that presented to the epidemiologist. Let's review the triangle of epidemiology. So we have the host, the environment, and the infectious agent. The agent is the cause of the disease. The host is a human or an animal that is susceptible to the disease. And the environment includes those surroundings and conditions external to the human or animal that cause or allow disease transmission. And time, which represents the incubation period, life expectancy of the host or the pathogen, and duration of the course of the illness or condition. We have an advanced model of this triangle of epidemiology, which recognizes that disease states and conditions affecting a population are complex and that there are many causative factors. So the causative factors replace the simple concept of the infectious agent. This implies the need to identify multiple causes or etiologic factors of disease, disability, injury, and death. Let's move to some disease transmission concepts. A fomite is an object that can harbor an infectious agent and is capable of being a means of transmission. An example is a door handle or a utensil that can harbor an infectious agent. Fomites are common routes of infection in hospital settings. For example, we have the stethoscopes, the white coats. We should always make sure to sterilize them to prevent infection or transmission from one patient to another. A vehicle is a concept that is closely related to a fomite. A vehicle is a non-living intermediary, such as a fomite, food, or water, that conveys the infectious agent from its reservoir to a susceptible host. So the focus in this concept is the movement or the conveyance of the infectious agent. Next is a vector. So this is just a review from last semester. A vector is an invertebrate animal such as a tick, mite, mosquito, blood-sucking fly that transmits infection by conveying the infectious agent from one host to another. It can be mechanical or biological transmission. So mechanical if the infectious agent is just carried on the invertebrate animal, but the life cycle of the infectious agent does not occur inside the animal or on the animal. And for biological transmission, then, if it involves the life cycle of the infectious agent, then that would be biological transmission. A vector does not cause disease itself, but it can be part of the infectious process. Next is the term zoonosis. A zoonosis is an infectious organism in invertebrate animals. Examples are rabies virus, which we know are present in dogs, Bacillus anthracis, which can infect livestock like sheep and cattle, Ebola virus, which can infect primates, and influenza virus, which can infect birds, swine, horses, and dogs, among others. So these can be transmitted to humans through direct contact, a fomite, or a vector. Let's review the concept of reservoir. This is the habitat, whether living or non-living, including human reservoirs, in or on which an infectious agent lives, grows, multiplies, and on which it depends for its survival in nature. Next is a carrier. A carrier is a person who harbors the infective agents without showing signs of disease, but is capable of transmitting the agent to other persons. So they are very important in epidemiology and in public health because they can cause the spread of disease, but we are not able to easily identify them because they do not show signs of the disease. Lastly, let's just briefly discuss modes of disease transmission. We have direct transmission and indirect transmission. So for direct transmission, this is the direct and immediate transfer of an infectious agent from one person to another. This requires physical contact between an infected host and a susceptible person and the physical transfer of a pathogen. Examples of direct transmission include sexually transmitted diseases such as HIV/AIDS, chlamydia, gonorrhea, hepatitis B, herpes simplex virus, and herpes. We also have perinatal mother-to-child transmission, such as through toxoplasmosis, and skin-to-skin transmission for warts, impetigo, and athlete spot. For indirect transmission, it is when an agent is transferred or carried by some intermediate item, organism, means, or process to a susceptible host, resulting in disease. For example, this can be through air currents, dust particles, water, food, oral fecal contact, and other mechanisms. It's also vector-borne and vehicle-borne transmission is also under indirect transmission. While airborne transmission can be direct or indirect transmission. So if it's very close contact, then that would be direct transmission. But if the infectious agent is carried through the air through quite a distance, then that would be indirect transmission. So in summary, the description in epidemiology begins with the assumption that diseases do not occur at random. And we discuss the pioneers of epidemiology and some of their discoveries. And there are 3 standard questions posed to characterize the non-random distribution of a disease. Who gets the disease? Who is the person? Where does the disease occur for the place? And when does the disease occur for the time? Thank you. And if you have any questions, please email me or message me through Canvas. And see you on our live question and answer. Thank you.